Welcome to today's webinar from the New York State Quitline. It's a practical look at addressing tobacco use in relation to trauma for clinicians and others. My name is Tony Astron. I'm the PR and Communications Manager with the New York State Quitline. And for those of you who may be unfamiliar with us, every state has a quitline. We like to think we're one of the strongest, and we're a lot more than just a place you can simply call to get free patches, gum, and lozenges. We're so much more than that. We have trained tobacco treatment specialists on the other line when people call or text or visit us online for any kind of support to either cut back on their use of any tobacco and nicotine products, or of course, hopefully to quit altogether. Our website and all of our services are free. It's a one-stop shop of resources, both for those, again, who are looking to hopefully quit altogether, or for educators and or healthcare professionals, such as many of you who are on the webinar today. And our services go far beyond traditional tobacco. We also have support for people who use electronic cigarettes and other vaping products as well. So please, if you haven't seen our website, be sure to head there after the webinar at nysmokefree.com. We are part of New York State's comprehensive tobacco control program and based right here in Buffalo, New York at Roswell Park Comprehensive Cancer Center, backed by evidence-based research, celebrating our 25th year this year. A few housekeeping items to begin. This presentation is being recorded. We do have all of our live attendees muted. Participation is through chat only. You may submit questions to the presenters through the Q&A box. We'll mention a little bit later that we are going to try to get to as many questions as we possibly can, but anything that we're not able to get to in the allotted 60 minutes, we will be recording all those questions and then responding to them via email to everybody who has registered. You'll have the responses next week. This webinar does have CME available thanks to our partners at the University of Buffalo Jacobs School of Medicine. To get that CME credit, if you are watching this recorded versus live, it does require live attendance. After the webinar, we'll have a link at the very end of this presentation. We will then send it out momentarily this afternoon via email to fill out a brief evaluation, which will then ask you, would you like to receive the CME credit? And then it will have another brief evaluation to get that. It's a very easy process. And for those of you maybe not looking for credit, but a certificate of completion, of participation, those will be available as well. This is just a slide of our faculty disclosure policy, ensuring fairness, balance, objectivity in all of our programs. And for our disclosures, you see our listing of presenters, which we'll introduce in just a second, but we don't have any discrepancies, any conflicts of interest to report, no relationships with ineligible companies. As you can see here, again, no conflicts of interest to declare. There's no funding associated with this webinar, no financial benefit for our presenters. As with everything that we do at the Quitline, it is one of those few great things in life that is still free. When we say free, it is free. And this is part of our educational connections to you to hopefully help with your practices and your learning and knowledge. And speaking of learning knowledge, we want to mention that the term tobacco throughout this webinar, it does refer to the use of manufactured combustible commercial products and vape products, and not the sacred medicinal traditional use of tobacco by Native American nations and other indigenous groups. Also regarding wording, we do recognize there are changes underway currently, both locally and nationally in the landscape of healthcare. We have made our efforts to the best of our knowledge to adjust our written, verbal technology to comply with new guidelines. And as mentioned earlier, we're going to try to answer as many questions as we can towards the end of this webinar, and anything that we do not get to, we will be sure to follow up on afterwards. Let's briefly recap what the goals are of today's webinar. Our webinar is designed here to educate attendees on the interconnectivity of trauma and tobacco, while providing practical tips to integrate in your current efforts. You'll also learn about a new resource available through the New York State Quitline, Trauma and Tobacco, a Practical Resource Guide. just putting the finishing touches on it now, and we'll mention at the end of this webinar that will be coming to you next week via email. So stay tuned, but you'll get a sneak peek of how that guide is like and how to use it as we go through this webinar. And that leads us to our objectives. At the conclusion, you should be able to define trauma and its connection with commercial tobacco use and recovery, and also identify 2 reasons that healthcare professionals and others can benefit from increasing their understanding of tobacco and trauma. And then finally, in reference to the guide that was just mentioned, you'll learn 3 key aspects of it that you can apply to your clinical interventions. So without further ado, it is my great honor to present to you our featured presenter, Yulim Song. She is the project manager with Practice Improvement and Consulting with the National Council for Mental Well-Being. I think you'll find her remarks to be not only insightful, but refreshing. She is certainly an expert on all things related to trauma. And with that, I'm going to go to her presentation and turn it over to Yulim. Yulim, welcome.
Oh my goodness, thank you so much for that introduction, Tony, and thank you so much for having me. Thank you to the phenomenal team at the New York State Quitline. Hello, everyone. I'm Yulim Song. I'm very grateful to be here with you today. Just a quick note on language and terminology, although Tony just went through one of the pieces for us. Here at the National Council, we define mental well-being as thriving regardless of a mental health or substance use challenge, which may also be referred to as a mental illness, substance use disorder, addiction, or dependence. And any reference I make to tobacco today will be referring to the commercial tobacco use and not the sacred and traditional use of tobacco by some American Indian and Alaskan Native communities. Next slide, please. And so just a quick introduction. I'm here today on behalf of National Behavioral Health Network for Tobacco and Cancer Control. We are one of 9 CDC national networks committed to eliminating tobacco and cancer-related disparities. Through NBHN, we provide training and technical assistance through webinars, communities of practice, and many other valuable resources focused on addressing tobacco and cancer disparities for individuals experiencing mental health and substance use challenges. Through NBHN, please visit our website, www.nbhnetwork. We just changed our URL, so it takes me a moment to get around to it, but we have, you will be able to stay in touch with upcoming opportunities of a variety of different resources by finding us there. Next slide, please. And so NBHN is one of 9 national networks. As I've mentioned before, we are a consortium of 9 national networks sponsored by the CDC's Office on Smoking and Health and Division of Cancer Prevention and Control. I also strongly recommend that you check out any of our other sibling networks, which all serve their own priority population pertaining to tobacco and cancer-related disparities as well. Next slide, please. So really quickly, NBHN's learning agenda describes our approach to providing training and technical assistance to strengthen the capacity of public health, mental health, substance use, and addiction recovery organizations to address tobacco and cancer-related disparities. And our TTA is designed to address the spectrum from technical challenges, which are well-defined challenges with known solutions, to adaptive challenges, challenges that require diverse perspectives and skill sets to identify and implement effective solutions. And so moving on to the next slide, please. And on the other part of our learning agenda, we outline some of the ways in which we provide this TTA. And today we will be focusing on the key goal of implementing trauma-informed and resilience-oriented prevention and cessation messaging. Next slide, please, Tony. All right, so I just did a lot of talking. But I really just want to start on this slide. I want to wonder out loud what other priorities you may be navigating this morning to make room to reflect on how we serve our communities better today by being in this very presentation. I just want to thank you for your commitment to what I call hard work of serving our community. So thank you for being here. And moving on to the next slide. And for the hour we have today, I want to invite us on this path of compassionate curiosity, inward into ourselves and outward toward others. This is a photo of, if we can go back for just a second. This is a picture of a hike I went on in Washington State. It was Mount Rainier last summer. If anyone's been, it's so beautiful. And I love how supportive the nature feels as it scaffolds the path up to the peak. And I'm sure all of you may have a scenery in your mind that feels resourcing and grounding, that scaffolds your path of compassionate curiosity. And I invite you to hold it in your mind as we move through this presentation and asking ourselves lots of questions. Next slide, please. And really quickly, here are the learning objectives that were shared before. We will be defining trauma and its in connection with commercial tobacco use and recovery, and we'll be identifying how we can benefit from having a deeper understanding of this intersection. Next slide, please. So we'll quickly start on the note of what has caused the tobacco-related disparity we see among individuals with mental health and substance use challenges. So we know that the overall rate of cigarette smoking and tobacco use among adults have been falling, but individuals with mental health challenges have been neglected in prevention efforts, environmental and clinical interventions. We know that this disparity can be attributed to historical predatorial practices by tobacco companies, such as targeted advertisements, circulation of tobacco products in behavioral health facilities, and really research that perpetuated myths that cessation competes with behavioral health outcomes, which is disproven, as well as limited access to high quality care. And something we will be focusing on today, the intersection of a lot of these disparities in health outcomes are high rates of trauma experienced by these populations. Next slide, please. So taking a closer look at rates of tobacco use in mental health and substance use populations, CDC tells us that adults with mental health and substance use challenges consume almost 40% of all cigarettes smoked. Research finds that adults with mental health and substance use challenges are much more likely to smoke without compared to those without such diagnoses. And adults with mental health diagnoses attempt to quit at the same rate as those without, but are less likely to be successful. And yet we find that most individuals with mental health and substance use challenges want to quit smoking and want to quit using tobacco products. And research also shows us that smoking cessation improves long-term co-occurring substance use recovery outcomes as well. And so when we put these pieces together, a clear picture arises that individuals with mental health and substance use challenges are greatly affected by tobacco use, want to quit using tobacco, yet may face additional challenges. Next slide, please. And at the intersection of these challenges may lay trauma. We find through a wealth of research that exposure to trauma elevates risk for mental health and substance use challenges throughout adolescence and adulthood, and that a great majority of individuals in mental health and substance use treatment report a history of trauma. And we will dive deeper into this connection throughout, but research also shows us strong linkages between history of trauma and a variety of commercial tobacco use behaviors over and over again. And we really now have a good understanding that use of substances such as tobacco products can often arise as a coping mechanism and a type of solution that the individual may have to the emotional, psychological, and physical impact of trauma. Next slide, please. And so we ask, how is trauma defined? What is trauma? This is the official definition from SAMHSA that contains 3 key elements. Trauma results from an event, a series of events, or a set of circumstances an individual experiences as physically or emotionally harmful or threatening, which may have lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. And an important part of the definition being that traumatic events may be experienced by an individual, a generation, or an entire community or culture. Next slide, please. And this is an alternative definition that I also want to root us in. And this is a somatic definition of trauma that comes from Stacey Haynes. It reads, trauma is an experience, a series of experiences and or impacts from social conditions that break or betray our inherent need for safety, belonging, and dignity. And through this definition, we can think about trauma from the lens of these needs that every one of us have, which is to have safety, belonging, and dignity. And it helps us wonder how our body is made to cope when those needs are betrayed. Next slide, please. And we cannot talk about trauma without also talking about resilience. And these days, you may feel as though you are having to lean on resilience so much, and acknowledging that, it does us well to connect and remember that we all have such wells of inherent resilience within us, and this capacity to change and grow through adversity and risk. Next slide, please. And so returning to different dimensions of trauma, here is a quick graphic to show us the different levels of trauma as experienced individually and collectively, from individual trauma all the way to community and mass trauma. And in being trauma informed, we have to hold that all of these levels are interconnected and interact with each other, contributing to the larger impact of trauma on each individual. Next slide, please. And speaking of individual, I want to spend a quick moment on how trauma may impact how we show up as ourselves in the world. Here we have a graphic that says, we do not see things the way they are, we see them as we are. And trauma is just one of the aspects of the human experience that can impact the lens through we experience ourselves and others. Dr. Judith Herman, who's one of the founders of trauma theory, writes that the essential features of psychological trauma are disempowerment and disconnection from others. Trauma can profoundly affect our experience of safety, our sense of self-worth, and our ability to connect with others. And so when we're thinking about supporting others in the context of trauma, we really center considerations of empowerment of the individual and creating relational safety. Next slide, please. So shifting gears for a little bit, I want to ground us in the seminal study of ACEs as we talk about trauma and long-term health. ACEs is a term and a framework that comes from this 1998 study characterizing the relationship between childhood adversity and long-term health outcomes. And on the slides are some examples of ACEs that were defined in the study. The overarching findings of this body of research and really all of the literature that has built upon this framework since show us that ACEs are common and widely experienced, and that endorsing ACEs is correlated with leading causes of death, such as heart disease, cancer, chronic lung disease, and that multiple exposures to ACEs increase an individual's likelihood of engaging in health risk behaviors, such as binge drinking and using tobacco products that contribute to this long-term health outcome disparity that we see. Next slide, please. And so connecting these dots, we have a pyramid that shows us the mechanism through which adverse childhood experiences influence health and well-being throughout the lifespan. So we see us being situated in the generational embodiment and historical trauma to social conditions, and then experience of adverse childhood experiences that may lead to interruptions and disrupted neurodevelopment, create social, emotional, cognitive impairment, potential adoption of health risk behavior, to long-term disease and health outcomes. Next slide, please. But particularly zooming back in on tobacco, we find that there is a really strong relationship between ACEs and tobacco use, and not only just a simple correlation, but a dose-response relationship, meaning that the more ACEs an individual endorses, the more likely they are to be affected by their tobacco use behavior. So this dose-response relationship is replicated across many different types of tobacco use behavior, such as likelihood of using tobacco, earlier initiation, likelihood of using starting in youth, likelihood of tobacco use behaviors to endure into adulthood, patterns of more persistent smoking, severity and intensity of nicotine dependence. And we're seeing research showing us this relationship in e-cigarette use and vape use as well. Next slide, please. And speaking to how trauma interacts with individuals' recovery journey, continued research finds that individuals that report trauma histories tend to use commercial tobacco, anticipating that it will help reduce their distress and negative affect. And in pursuit of their treatment, individuals with trauma can be affected by the impact of their trauma-related symptoms, experience higher levels of stress, which makes them experience greater barriers to cessation and greater severity of withdrawal as well. And so these insights help us kind of connect the dots and help us understand what kind of challenges these individuals may be facing in their recovery journey with tobacco. And it also helps us reframe tobacco use as this replaceable coping mechanisms in our supporting these individuals seeking recovery from tobacco use and pursuing mental wellness as a whole. Next slide, please. So I want to summarize all that's being said in these slides with this, that every individual we meet is carrying their own story, the history of the context that shapes them, and adaptations that served the navigation of their story. And really holding this idea, I think, helps us think about how we apply this trauma-informed care in the way that we support these individuals in their recovery and really also ourselves in this hard work that we do. Next slide, please. And now getting into what trauma-informed care looks like, we are going to inform ourselves on the neuroscience of trauma and the nervous system for a little bit. This is a very, very simplified diagram of how our brain prioritizes function and information processing from the brainstem up to the prefrontal cortex. So the brainstem, which is responsible for our survival, is constantly seeking through all this overwhelming information that we are taking in and asking the question of, am I safe, over and over again? And if the brain appraises, so if our nervous system appraises safety, our priorities can now shift up the ladder to the limbic system, responsible for emotion and memory, which asks, are we connected to others? Or we make sense of our social connection. And so again, I want to bring us back to the original definition of trauma that I shared with you, seeking and thinking about how our body is seeking for our needs of safety, belonging, and dignity to be met. And only once these appraisals and these needs are attuned to, then can we move up to the prefrontal cortex in our priorities, in our thinking and planning brain, and which helps and supports, give us the full capacity to learn, to be strategic, to be intentional, and to create lasting change in our patterns of behavior. And so the key takeaway from this ladder is that our brain and our nervous system will ask in priorities, are we safe? Are we connected to the people and the environment around us? And then, only then, can we really fully ask, what can I decide on? What can I strategize on? How can I be most intentional? And this applies to every nervous system in the room, including yours and including mine. So next slide, please. So just another slide on our nervous system that helps us understand trauma-informed care. I love this slide because it actually shows us that our nervous system and our body is so wise. In a very simplified way, our nervous system orchestrates our body so that we can respond to perceived threats, risk in our environment, whether that be social, emotional, physical, while assessing what resources we have, and create an instinctual survival response to navigate the stressor of the moment. So you may see familiar words, the big F's of the trauma response, the fight, the flight, the freeze, the fawn. Starting with the sympathetic nervous system when it is activated in response to a perceived threat. We go into a place of a fight or flight, mobilizing, which may look like frustration, irritation, anger, or a lot of worry and concern and anxiety and even panic. And when our parasympathetic nervous system is activated, we are more so in a space of prioritizing conserving our energy. So we see freeze behaviors that show up as numbness, lethargy, dissociation, shutdown. And you may be looking at this chart and listening to some of the words I'm saying and thinking that feels a little familiar, and we are always navigating activation in our bodies and trying to respond to the level of stress that we are being asked to navigate in our environment. But ultimately, when we are able to connect with a sense of safety, we are supported and regulated in a state of social engagement. At the bottom in the big green block, we see calmness and connection, a sense of settledness, not stuckness, and again, a sense of compassionate curiosity and our ability to do so towards ourselves and others. And so when we really take a look at how our bodies mobilize and activate to help us navigate our environments, these behaviors and responses our body may deem them necessary to respond to the stresses that we do face, and also respond to what kind of trauma and previous experience that we have had to navigate and cope with. And keeping that in mind, ultimately, we hope to create a sense of safety within our bodies, within our communities, so that we can stay and be encouraged to be in a space of social engagement to navigate our day-to-day. Next slide, please. And so ultimately, the takeaway from all of this neuroscience is that in response to great stress and trauma, our bodies move into this survival mode response to help us navigate forth. And then when we think about trauma-informed care, it's really important to think about how we minimize things that evoke this survival mode response when it is not necessary. And that reminders that we can do so by creating a deep sense of safety and connection. Next slide, please. And so before I hand over to the New York State Quitline team again, I want to outline just some key tenets that are the train tracks of our trauma-informed, resilience-oriented approach. And it really starts with changing the question from what is wrong with you to what happened to you and your people, and assuming that everyone is doing the best they can. Next slide, please. And we can apply these expectations to everyone, including ourselves. We do not have to specifically know where the individual in front of us have been in life for us to apply these tenets of trauma-informed care. we all face stresses, and if you have a nervous system, trauma-informed care affects you. And so applying universal expectations also can be a really important reminder in trauma-informed care. Next slide, please. And I'll leave you all on this note of the 4 assumptions and 6 key principles that's outlined in SAMHSA's recommendations for a trauma-informed approach. And it starts with the 4 R's, which is realizing widespread impact of trauma and understanding potential paths for recovery, recognizing signs and symptoms of trauma in clients, families, staff, and others involved with the system, responding by fully integrating knowledge about trauma into policies, procedures, and practices, and resisting re-traumatization. And the 6 key principles, as you see here, is safety, as we've just discussed, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender and sexual orientation considerations as these principles to consider integrating when thinking about trauma-informed care. And I believe Pat and Paula will be speaking more to what implementing these really look like in your work. So if I can turn it back over to the Quitline team. Oh, and a lot of these materials are included in our Incorporating Trauma-Informed Approaches and Tobacco Cessation Services guide. If you are interested in receiving this document, I'll drop my email in the chat, and please reach out to me there. Thank you so much.
Lots of fantastic learnings to take away, and now we're going to sort of pivot a little bit and transition into sort of the rubber meeting the road, and now integrating this into your clinical practices as well as the resource guide. So now it is my pleasure to introduce my fellow colleagues of our marketing and outreach team here at the New York State Quitline, Paula Celestino, our Director of Client Relations and Outreach, and Patricia Bax, our Marketing and Outreach Coordinator, who will take the slides from here. And please continue on. Thank you very much for the questions in the Q&A chat box. We will be responding to as many as we can towards the end of this webinar. But without further ado, here is Patricia.
Thank you, Tony, and thank you, Yulum, for that inspirational and educational presentation. I always learn something listening to you, and it's a great privilege. I'm here to talk about the exciting new resource we have available at the Quitline, our Trauma and Tobacco Practical Resource Guide. Before we get into specific examples of how to use the guide, I'd like to take a moment to give you a little background about how the guide came to be in terms of the actual content. So Tony, on the next slide, you'll get to meet our team. In January 2024, the National Behavioral Health Network for Tobacco and Cancer Control conducted a 6-month course entitled Trauma and Tobacco Community of Practice. We were very honored and humbled to be accepted as Roswell Park Comprehensive Cancer Center on behalf of the New York State Quitline, and we were accepted into the community of practice. And it really was a life-changing experience for me. And our team consisted of Paula Celestino, a project member, our wonderful Public Health Corps graduate fellow, project member Taylor Hansen, who unfortunately was unable to be with us. She's in school, in class right now, and myself, the project lead. We were asked to complete an action plan. And as part of the action plan, we developed the Trauma and Tobacco Practical Resource Guide. When we talk about how the guide was formatted and how we really took a look at addressing the specific content, on the next slide, you'll see that we reached out to those individuals all across New York State who could guide us with their feedback on how they would use this guide if it were to be created. We not only surveyed our New York State partners, but we also did some informant interviews. And I'll highlight one of those interviews at the end of the presentation. What we determined was that there are very specific areas of identified use for this guide, which could include personal education, learning more about trauma, and that taking that knowledge to help educate partners, training within an organization. Paula will talk a little bit about the importance of including trauma-informed approaches into an organization. Community education, when you do community outreach, also policy work, and finally, assisting those individuals who use commercial tobacco and or vape. On the next slide, you'll see a little bit more about the contents of the actual guide. As Eula mentioned, we all experience trauma, and that's different for all of us. It affects everyone. It affects our families, ourselves, our friends, communities, locally, statewide, nationwide. And that trauma is something that understanding and raising awareness can help us as we advance our efforts, especially when it comes to tobacco outreach and marketing. When we looked at the table of contents, we want to make sure that you understood how this evolved, meet the team, how to use the guide, which really was based on the information that was provided through the survey with our partners. And then we also wanted to include a resource appendix, works cited, and a glossary to expand your knowledge base, tools, and resources. We want you to share this resource. We don't want it to be just in a folder on your desktop, or if you print it, to just sit on your shelf. We want it to be active and breathing, something that you refer to often, because we believe that the content that is in this guide can help to shape and form some of the work, the wonderful work that you're doing in addressing tobacco dependence treatment. On the next slide, we wanted to make sure that we provided some takeaways. How could you actually use the guide with very specific examples? And Paula Celestino is going to lead us in some suggestions of how you can implement this guide. We particularly honed in on page 18 of the guide, where this is a graphic from the Substance Abuse and Mental Health Services in 2023, and she will focus on recognition and response. At this time, I'll turn the presentation back over to Paula.
Oh, thank you, Pat. Thank you so much. And just to recap on this slide, first I'd like to thank you, Lim and Pat, for their presentation and the great information that's already been presented in order to put these next few slides in context. So as Yulim had pointed out, there are 4 assumptions for trauma-informed approach: realization, recognition, response, and resisting. And as Pat mentioned, I am going to focus on recognition because this is kind of where the rubber meets the road, the kind of practical logistics that could be had for yourselves and in your organization in order to implement trauma-informed approach. So we'll go to the next slide, please, Tony. So starting with screening and assessment, it's important to review your screening and assessment forms for use of trauma-informed motivational questions. Do you have similar questions in there already? Do you need to be putting some of those questions in your screening and assessment? Have questions which address the impact of trauma on commercial tobacco and vaping use. Of course, it's a great place to start when you want to provide someone with help with their commercial tobacco and vaping use. It's important to provide a safe environment to conduct the screening and assessment to help facilitate a connection between you and your patient or client. And ensure that your staff are trained with in-person first language and trauma-informed responses. And include in the trainings how to recognize differences between stress and trauma. This level of knowledge will help folks to be more specific and more helpful to those you serve. Next slide, please, Tony. To continue with screening and assessment, some samples of trauma-informed screening and assessment questions might include: what is important for me to know about you as we begin this assessment? And what are some of your reasons to quit tobacco or vape use? How do you see your life when you quit using tobacco? And tell me about the support you have that could assist you in quitting tobacco use. Of course, everyone has their own style, and organizations might, form their own questions. These are examples, and you might wrap it up with something like, thank you for this opportunity to get to know you more and how we can work together. I appreciate your willingness to openly share your responses. Next slide, please. When we move on to supervision practices, some of the key things to remember is that it does begin system-wide and go through your whole organization to commit to addressing the interaction between trauma and tobacco use. Train supervisors to recognize the signs of trauma in their employees and align trauma-informed initiatives with existing workplace initiatives. Provide an environment for employees to feel safe, secure, and able to trust. Build in safeguards in the workplace to respond to employees with compassion and resiliency. And use strength-based language, which I believe Yulim already mentioned, but ask what is right with you rather than what is wrong with you. Next slide. Some employee assistance tips. Remember that trauma is not isolated, and the experience of trauma ramifications could be widespread and quite diverse for an individual. Provide employees with an environment of safety and trust, and be sure your staff are aware of trauma assistant resources and how to access them. This is, something I think quite important, which may be a little bit harder to attain, but having a safe space for employees to access throughout their working hours to reinforce and help avoid re-traumatization when they experience the emotions of their patients and or clients. Next slide, please. I'm going to turn it back over to Pat, who's going to give you some more specifics on a good program we have and others have to help you with tobacco treatment for your patients and clients.
Thank you, Paula, for providing those specific examples. And we wanted to bring it a little closer to home and share with you tobacco treatment specialist training that we have here at Roswell Park. It's offered twice a year, and you'll see in the bottom right-hand corner of the slide, you'll see that there is a link if you'd like information. Our next training is in May, and we have one in October, and we also have scholarships available. So I'm sure Tony can put the link in the chat in case anyone would like to investigate that further. With the trauma-informed systems we approach, what we do is we address this in the module of healthcare delivery systems. This is a module that I actually facilitate, and the purpose is really to take a look at how toxic stress and trauma actually impact the community and how that affects the system delivering services. We do a group activity, we break up into smaller groups, and it allows for a closer look at a fictitious clinical setting which has been impacted by trauma. And the small group activity allows for participants to identify effective strategies for change. What we find is that there's very productive conversations about what it means to be a trauma-informed organization. And many of the participants had no idea of what that actually means, and they walk away from this with increased knowledge about this important topic. On the next slide, you'll see that we have another example that happened actually right here in Buffalo. Many of you may have heard on a national level, it was certainly on national news, and it happened back on May 14th, 2022, where we had a racially motivated mass shooting at a supermarket here in Buffalo. It has changed our city and our community forever because the impact of trauma was not just on that day, but it also is something that is impacted and continues to be far-reaching. It has changed our community forever. We had different ways of how the community could respond, and Western New York chose to respond in a healing way. Everyone, no matter of race, background, religion, everyone came together to support the victims' families, the residents of East Buffalo, first responders who were tremendously impacted, and all those others who felt the impact, the trauma of this horrific tragedy. So how did Buffalo respond? How are we continuing to heal? Creating that safe environment for grieving is so critical. We talked about safety throughout this whole presentation. In Buffalo and beyond, there were provisions of food services, mental health services, spiritual support, community resources. Donation links were set up all across the area, and donations came pouring in from the nation and all over the world. Specifically to Roswell Park, Paula and myself, we had an opportunity to actually go to the store once it was reopened in a very holistic way. And as you can imagine, it was very humbling for us. It was very traumatizing for those shoppers that were coming into the store. It was the only place they could go for their food. However, we were able to set up a table and to actually talk face-to-face to individuals who used commercial tobacco and link them directly to the Quitline services. It was a wonderful experience and something I will never forget. What I'd like to do in terms of wrapping up my part of the presentation before we turn it over to Q&A is I want to give a huge shout out to Will Mabey. He's the Community Outreach and Engagement Coordinator with Indigenous Cancer Health here at Roswell Park. He was one of our informant interviews, and I have to say that his interview, Taylor and I interviewed him, and kudos to Taylor because she really was the mastermind behind compiling the document. But we had this life-changing experience with Will, and we wanted to share some of these important reflections as we close the presentation today. On the next slide, you'll see some of the key statements that were made and reflections, and I think I'm just going to highlight a couple of them for the sake of time. But when it comes to being trauma informed, if you take away anything from this presentation, it's really to learn about what does that mean. It means to be more of a listener because you're creating a safe spot for people to talk about the things that they're stressing about, that they're feeling traumatized. When we look at trauma-informed approaches, they need to be absolutely need to be part of a commercial tobacco curriculum because we can't separate the two when it comes to tobacco and trauma. It's very nuanced and complex. And we know that some Indigenous people, they use tobacco because it helps them to heal from trauma, and an individual may carry grown tobacco to protect themselves from harm. And sometimes the healing journey is as difficult as the trauma itself. Recovering and healing from trauma is not linear. We must first become aware of the trauma and then take action. And one of the reflections that I think will forever stay with me was this statement. We have an obligation as healthcare professionals and those helping other people to remind them they're worth more than a cigarette. Their lives matter and they are valued. And there are just a couple other comments that reflections I'd like to mention. We talked about intergenerational trauma earlier. It's not something that necessarily is learned, it's passed down, and that we see this with the Indigenous population, leading to feelings of guilt and shame and fear. And that also is about, and really most cultures have an individual experience. It doesn't look the same. It's not a cookie cutter approach. We have to look at, especially within the Indigenous community, the different cultures and where people within each community experience and practice it differently. Behind every cigarette, there's a whole person with all life experiences that brought them to this point. And when we talk about being trauma informed, it's a paradigm shift of how we can best assist smoking behaviors. Understanding trauma may be the driver. It allows us a tremendous opportunity to connect and empathize with those using tobacco as a coping mechanism, looking at that as a coping mechanism versus a character defect. In conclusion, I would like to acknowledge all of the individuals who helped to make this guide possible. That includes the National Behavioral Health Network team for just not only the support during the community of practice, but ongoing support, and also ULM for being here today, And another shout out to Alex Hurst, who is also part of the National Behavioral Health Network team who helped to compile this information. We'd like to thank the New York State Department of Health, Bureau of Tobacco Control, our colleagues here at Roswell Park, especially Tony for being our master of ceremonies today, and also for editing the guide. And finally, our expression of gratitude to you, the participant. You took time out of your very busy day to be here. You prioritized this important topic, and you have a passion and commitment to this critical public health issue. It is our hope that this guide, this presentation today, will help advance the work of trauma and tobacco integration in our communities across New York State. Thank you very much, and I'm turning it back to Tony. Thank you.
A lot of information from our fantastic speakers today. If all three of you would like to come back on camera, please feel free to do so. We have a few more minutes left before we reach the top of the hour. We want to be respectful to everyone's time. I know that we are having a few issues which we're going to navigate for future webinars. It appears some people have access to the Q&A button, others do not. To verify, to reiterate again, if you are having trouble, please feel free to go ahead and put your questions in the chat. We'll transpose them later into the Q&A. I know we're waiting for a couple of responses here. One question that came in, and this is probably more on the Quitline standpoint for either Paul and Pat, but and certainly this ties right into trauma and treating it, but guidance in terms of mood changes with nicotine withdrawal and seeing symptoms of depression as well as anger, agitation. Anything you could talk to about what the Quitline may offer or just general guidance. I know certainly this is something that our trained tobacco treatment specialists talk through when navigating triggers and discussing a quit plan.
Well, I think just to follow up on what you said, Tony, we've got highly trained tobacco treatment specialists on board, both digitally and by the phone. And we do screen for questions around stress and anxiety and other mental health conditions. And so they are provided with that information through the assessment and are able to address some of those things kind of upfront and throughout the person's ongoing treatment should they decide to continue to talk to us for a phone call or two or three. And finally, to that point, and Pat can add on, is that we have enhanced services for people who report some mental health conditions and anxiety, whereas our standard of care is 4 weeks of nicotine replacement therapy and 2 calls. For folks reporting those conditions, we offer up to 6 weeks of nicotine replacement therapy and 6 calls. So there is some more robust services available, and they are tailored to the person's condition. So Pat, if you'd like to add anything.
I think it goes back to what we talked about, not using a cookie cutter approach, that each person is an individual. They bring different life experiences. And that's the importance of the coaching component, in addition to the physical, addressing the physical addiction through nicotine replacement therapy. But the tobacco treatment specialists can also identify where are the areas that they can assist and offer guidance in addressing the behavioral, the habitual, the psychological aspects of a person's addiction.
Are at 11:58, and we do have some other questions here that are a little bit more related to housekeeping. What we're going to do is we're going to wrap up. I'm going to go to this next slide here and also sort of simultaneously answer a few other things that are here in the chat. So first of all, this link here, please don't worry about trying to scribble this down. Everybody who has registered for this webinar, whether you're here live or not, you'll receive this email early this afternoon from me. It will come in from Anthony Astron. I go by Tony, of course. But you'll see that that is the evaluation for today's webinar. It's short and simple. And at the end of it, it will redirect you to ask if you would like CMEs or not. We have a deadline of the following Friday to receive that credit. I promise you it's a very easy, simple process. We are going to be sending a copy of the presentation slides in PDF format to everyone as well. It's that you'll have that as a resource. In terms of the recording, I am excited to let you know that right now, nysmokefree.com is undergoing a transformation of sorts, a whole new look, better navigation, easier on the eyes. And when that is up, which is going to be tentatively later in March, there'll be a whole new section of all sorts of educational resources. And our plan is to have a recording of this webinar as well as past webinars up there. So stay tuned. We'll include more details on that through email. And in terms of other great resources that the Quitline has to offer, yes, we do offer multiple languages, and in fact are translating many of our materials to New York State's most popular languages. So currently we have most everything in at least English and Spanish, and you can always head to the website to place your order if you do need materials for your clients, patients, or guests. So with that, we are at 12 o'clock. I want to thank everybody for attending. I want to especially thank Ulam, Pat, and Paula for sharing your knowledge. We hope that you have gleaned quite a bit of information and ideas related to the intersection of tobacco and trauma use. There are so many ways that they are indeed linked, and so many of us can identify whether it's in a minor way or a major way of how trauma affects our input, our outlook on life, and why, unfortunately, trauma really does play a role in really creating this furthering addiction to nicotine products and making it harder to quit. But that's why we're here, for the education. And just remember that for those of your patients, clients, guests in New York State, or maybe you yourself, if you ever need that extra assist, we are always here 7 days a week. So please, if you're not already signed up to our listserv at our newsroom, sign up. More detail coming through email, and then that way you can stay tuned to our next webinars coming up and latest educational materials to help yourself and your guests. But we hope that all of you have a trauma-free rest of your day, and thank you once again for participating in the webinar. We'll see you at the next one. Take care, everyone.